1 second, just before you do that, Karen, are you connected in? COVID, yeah, that should be it. Just join the live event and then she'll control your screen. Oh, you don't have the app, or you can just watch on the web.
We need to be unmuted.
There you go. Hi, everybody. So everybody can see me waving my hands like a crazy man. My name is Sunil Varghese. I'm an infectious disease doctor here at the Queensway Carleton Hospital. Thank you for joining today's webinar. This is the first in a series of webinars that are going to happen over the next month or so regarding COVID and COVID-related issues. Today's webinar is structured around setting the context of COVID within our Champlain region. So to do that is to do that is going to be Dr. Karan Sharma, who's one of my ID colleagues here at the Queensway Carleton Hospital. After setting the context, we're going to turn the camera over to Dr. Samantha Halman and Dr. Isabelle Desjardins, who are going to provide a clinical picture of managing COVID on the wards. With that, just a couple of housekeeping things. If you have any questions, I believe you have a chat function or an ability to ask questions that way, and we will moderate those questions and I'll bring them up. And we'll do the questions after both the presenters have finished. Okay, with that, I turn it over to Dr. Sharma.
I don't have Dr. Sharma logged into our feed here.
He might have come up as anonymous. So. Hi, Catherine, were you able to find him yet?
I'm looking. I just don't see him under our presenters tab. Did he log in through the link that I sent?
Yeah.
Okay. So let me see if I can troubleshoot.
That's okay. If not, what I can do is he can just use my computer and he can just email me his presentation. We can share from there.
Let's do that. I'm going to work on it on the side, but maybe that might be best just for keeping time.
Thank you. Sure. Okay. My apologies, everybody, for these technical glitches, but we'll be on the road in just a minute. Did you send it? Okay, there we go. Okay, so his presentation is up. If you can screen share now.
Hi, my name is Karan Sharma, one of the ID physicians at the Queensway-Carleton Hospital. Can you guys hear me okay?
Yes, we can hear you. Are you able to share your presentation? There should be an option to share your screen.
Can you see it now?
We did just have it. We lost it.
Oh, okay.
Yeah, you're good to go.
So I'm just going to talk about the epidemiology of COVID, especially focusing on the epidemiology here in Ontario and our local area. So I have no disclosures. So just a brief timeline. The first case of pneumonia linked to Wuhan seafood market was in December 28th. China CDC has a protocol where if there's any unknown pneumonia, they do automatically reflex PCR for SARS coronavirus because of the SARS in 2003. And so by doing this by January 8th, they were able to identify novel coronavirus. And by January 11th, there was a first case outside of China in Thailand. And by basically 17th, they had implemented strict screening measures. In Canada itself, the first case was reported on January 23rd, where a 56-year-old male presented to Sunnybrook Health Sciences Center with fever and non-productive cough. They had just returned from Wuhan, China, 1 day prior. And at that point, the nasopharynx and throat swab was positive for pan-coronavirus, as well as it confirmed SARS-CoV-2 sequencing. So it was the first case in January 23rd, 2020 in Toronto. So currently, when we look at the total numbers in Canada, this is as of yesterday. I know there have been around 413 new cases just in 1 day, so that number has gone up. But as of yesterday, there was 80,000 cases in Canada, and most of these cases are really coming from Quebec and Ontario. It seems to be the hotbed. When you look at the mortality in Canada, we've had around 6,000 deaths. Again, most of them are from Quebec and Ontario. The estimated mortality is 7.5 if you look at these numbers, 7.5%, but slightly overestimating because we weren't screening. Screening wasn't as robust, and some would argue still not as robust. When you look at Ontario itself, we've had around 23,774 cases. Again, this is as of yesterday, with 1,962 deaths. Around 991 hospitalizations with 160 people in the intensive care unit, requiring stay in the intensive care unit. This is kind of the curve that we're seeing right now in Ontario. So it really started picking up in April, and then now it seems we're hitting a plateau. Most of the people have recovered, but here's the number of deaths has now kind of remained pretty steady. When you look at the number of new cases in Ontario, it's kind of plateaued. The highest was in end of April, but now it seems to be we're reaching a constant rate of around anywhere from less than 300 to 400 cases on a daily basis. When you specifically look at COVID in Canada, we've had around 1,849 cases and around 210 deaths. And 44 people have required hospitalization, and currently there are actually 24 ongoing outbreaks in institutions. So this includes long-term care facilities and hospitals and other nursing homes. When you look at the epidemiological curve in Ottawa residents, so really it's end of April is when we really started to hit a spike over here, and that was driven predominantly by COVID spreading into healthcare institutions. Just anecdotally, we have an institution that's close to us, which there are 300 patients in it, and around 100 and little bit more than 140 of them, I believe, have been tested positive for COVID. That's really driving the number of cases in Ottawa currently, but this seems to be coming down. So when you look at the exposure and settings of confirmed COVID-19 in Ottawa, so predominantly now we've been driven by institutional cases and then contact with travel cases, contact with positive cases. Number of travel cases is really small now. And then when you look at age, gender, and occupation of Ottawa residents, really it's from 20 to 29 onwards, all the way to age 89. There's been a steady, splattering of cases. What's interesting is that when you look at this number over here, healthcare providers, 498 have been diagnosed, which is around 27% of total diagnosis. So yeah, definitely a lot of healthcare providers and first responders have been diagnosed with COVID as well. When you look at the mortality, at least in Ottawa and surrounding area, the cumulative mortality is around 11%. And as what we're seeing in other population studies coming out of China and Italy and even USA, the mortality definitely rises as your age rises. So highest mortality we're seeing in age 70 to 79 and 80 to 89 onwards. Unfortunately, we've had one death in healthcare provider as well. Sorry. So when you look at the hospitalization, around 12% of people who've been diagnosed with COVID in Ottawa have required hospitalization. Of them, 3% have required intensive care stay. But what's interesting now is like when you look at the hospitalizations, even though the mortality is mostly in the elderly people, but the hospitalizations have actually a lot of people, not an insignificant amount of people are being hospitalized from age group 50 to 59, 60 to 69, and 70 onwards. And same with the ICU. So even younger people are being hospitalized, and some of those younger people are also being transferred to the ICU. When you look at the total number of COVID-19 outbreaks in Ottawa institutions, as you can see, we've had few outbreaks. I mean, Queensway-Carleton is just having an outbreak on one of our floors. But yeah, right now, most of the cases are driven by institutional outbreaks. So currently, as of right now, we've had hospital outbreaks and long-term care retirement outbreaks as well. When you look at the surrounding Ottawa area, in Leeds, Grenville-Lanark district, we've around 341 cases. In Eastern Ontario, that Cornwall area, 142 cases. And Kingston area, 61 cases. And then Renfrew County area is around 21 cases. So that's the Ottawa surrounding area we're looking at. So that's kind of like the brief overview of the epidemiology of COVID in Ottawa and surrounding area. Any questions about that? If not, I will pass it on to Dr. Verghese.
All right. Thank you, Karan. I'll just stop screen. Okay. I don't have access to. Let me just pull up the chat. Okay. So thank you, Karan. If you do have any questions, please enter it into the chat. The Q&A is open. Okay, and I will take note of the questions and we can share them with the group and get some answers afterwards. Right now, I'd like to turn it over to Drs. Halman and Desjardins from the Ottawa Hospital to talk about the lessons learned from 4 weeks on the acute care COVID service. Thank you.
Okay. Sunny, just nod if you can hear me. Perfect. Okay. So thanks for having us. Isabel and I are in the same room here. So we're both general internal medicine docs at the Ottawa Hospital. We're both based out of the general campus. And we have been Team COVID for a while now. So we'll try to share some of our clinical experiences looking after these patients. 1 second. Having a slight issue moving the slides. Okay, give me 1 sec here. We'll just try to go through. I want you to go away. Okay. Just one sec, sorry, I'm seeing a different view on my screen than what you guys would be seeing, so. Everything works when you test these things, and yet. I'm gonna stop sharing my screen just one second, I'll try to share it again from my side.
Also, just to note, there will be about a 20-second delay between what you see and what the attendees will see.
Sounds good.
While we're waiting for that technical fix there's one question in the chat box that says, when people talk about the number of people who have recovered, what does that exactly mean? Is it based on the people who are admitted to hospital or institutionalized? I'll just hand it over to Karin to answer that question.
It's all those people who've been tested positive for COVID. So by nasopharyngeal swab or throat swab, either if they're outpatient, inpatient, or whatever, and they've kind of basically recovered to the point that they've no symptoms, are doing well post 14 days. Public health authorities have followed up with them. They're off precautions. That's what I mean. So it doesn't necessarily pertain to hospitalized. Just anybody who's been diagnosed by a test, a PCR test, and they've recovered from it.
Okay, I think Drs. Halman and Desjardins are ready now. Is that correct?
Sort of, because we what we're seeing on our mutual screens is very different than what the attendees are able to see, which is a bit odd because that's not what was happening when we were testing this.
Okay. Okay. So in the meantime, if there are any other questions, please enter into the chat. I will say that next week, for the next presentation, we're going to have a more ID-specific discussion on COVID, specifically what is the virus, how does it work, how is it spread, and attached to that, we're going to have an infection prevention and control and personal protective equipment discussion. So the two issues there are linked quite closely, and so we're going to spend some time at the next assessment, the next time we're together talking about those two issues.
We have fixed it now that I have shown every one of you of my calendar simultaneously. Okay.
Great, thanks.
Thanks. Okay, so sorry about that, everybody. We were just going to show an idea of some of the clinical courses, what we've seen in these patients. We'll talk about some of the patterns. We'll talk briefly about treatment, or at least what we have been doing. And then we were asked to just talk a little bit about how you manage life while you're on a COVID service. So just starting first with the clinical course. So we have found that the people who present early with dyspnea and hypoxia really do not do well. And we've tried to illustrate some of these things with some cases for you guys. So the first case is that of Mr. D, who's a 74-year-old gentleman who had pretty benign past medical history, hypertension, dyslipidemia. He'd been a lifelong non-smoker, very independent, played hockey 5 times a week, a very fit guy. He didn't have a travel history. There was a possible contact with a nephew that had traveled to Cuba, but wasn't known to be COVID positive. His wife actually became symptomatic first, and then several days into her illness, he became symptomatic. And his first presentation was actually micturition syncope, which is interesting because we've had quite a few fainters, if you will, in terms of people who've presented. He tested positive on April 11th, which is actually the day that he came to the emergency room. And his presentation was secondary to progressive cough, generalized weakness, and his family felt that he was just kind of off. He wasn't delirious or acutely confused, but wasn't quite himself. Hemodynamically, when he came in, his blood pressure was a little bit soft. He wasn't febrile initially, but he was hypoxic immediately at 82% on room air. In terms of his initial investigations, and you'll see that the same pattern kind of repeats itself. These are the typical blood work that we've been sending on these patients. So he had some evidence of an AKI, and his inflammatory markers were actually all quite elevated on presentation. He was leukopenic or lymphopenic, which is something that we also see, and he had a bit of a transaminitis as well. His initial X-ray showed a pretty classic pattern of bilateral reticular infiltrates and not an overt consolidation. So by the time that he was admitted to the COVID unit, within 2 hours of presentation, he was up to 15 liters per minute. We revised goals of care to discuss that if he were to have a cardiac arrest, CPR probably would not be successful, and he changed to a category 2, which for us is ICU and intubation. By the time he got to the floor, he was on max tech at 100% and had a non-rebreather at 100% on top of that, and was barely maintaining sats in the 80s. We started him on hydroxychloroquine, and we'll talk about that a little bit later, and we transferred him to the ICU immediately. He had quite a long stay in ICU, so just over 2 weeks. And at that time, the strategy in the ICU was to try to avoid intubating these patients. He was prone for 18 hours a day. They were tolerating some hypoxia and sometimes very, very low sats that he would recover. They tried BiPAP, they tried CPAP, they tried a slew of different treatment, including ultimately Solumedrol. The X-ray that you see to the left of the screen is actually his X-ray 24 hours within admission, so rapid progression to ARDS. And unfortunately, eventually he passed away within 14 days of presentation. I was very surprised he lasted that long, truthfully.
This is more of a recent finding that we've seen. So we have noted a higher incidence of thrombotic events somewhat later in the presentation, so about 10 to 14 days after their initial onset of symptoms. And we'll just go over one case and then a few other examples. So Mr. G is 57. He really had no significant past medical history coming in, though one of those people who probably doesn't go to the doctors very often, and was subsequently found to be a type 2 diabetic in hospital, but not known prior to admission. Was a non-smoker, worked as a PSW in 2 long-term care, both of which ended up on outbreak. No travel history, and we really do believe that his COVID-19 contact was through work. It's very unclear when his symptoms started, but it started initially with some dyspnea, was tested on April 12th and found to be positive, but actually presented to the ED on the 27th, so 2 weeks out from his initial screening test, when he was talking daily with Ottawa Public Health, and on the 27th endorsed worsening dyspnea and some chest pain, and so they actually suggested that he go to the assessment center on Erin Road, and once he got there, he was found to be hypoxic with sats of 84% on room air, and so they called an ambulance and sent him over to the emergency room. These were his initial COVID-19 markers. You'll note that his D-dimer was just greater than 24,000. He had a fairly classic chest X-ray, and I will note that this was 2 weeks into his presentation. His CRP was high, but not extremely high. His ferritin was, again, not that impressive. His lymphocytes were actually normal. His liver enzymes were also normal as well. He initially was on nasal prongs and then subsequently needed 35% FiO2, was assessed by our CATCO study here at the hospital, which randomizes to Kaletra or standard of care, and he was randomized to standard of care. He was started on hydroxychloroquine and also on ceftriaxone and azithro for a possible superinfection. And given his D-dimer of greater than 24,000, we ordered a CT-PE, and he was found to have extensive bilateral PEs. He was slowly weaned off. His stay was quite prolonged, mostly for O2 requirements, and he remained still tachypnic and tachycardic on exertion, but felt primarily to be due to his PEs rather than to his COVID pneumonia. There have been now more and more reports of hospitalized patients with thrombotic complications of COVID, most frequently DVTs and PEs. In fact, in 2 studies, they found that the PE accounted for 80% of those thrombotic events, with an event rate of, I would say, on average, about 20%, so not negligible. And this is despite standard DVT prophylaxis. And we'll talk later about what we've started doing in terms of DVT prophylaxis for these patients at the Ottawa Hospital. Other manifestations that have been reported. So if you've looked around on the web, you've found probably pictures of COVID toes, which are believed to be macrovascular thrombosis of the toes. Our friends in ICU will tell us that people are clotting their dialysis filters, and for those even started on IV heparin, it's still very difficult to actually get them to reach their therapeutic anti-10A levels. There have been reports of MIs and large vessel strokes. I will say we haven't seen many of the cardiac complications here so far. And these are 2 images of patients we've also had. So on the left, a lady who came in and actually from a respiratory point of view improved, but was clearly obtunded and had a CT scan which showed these subacute infarcts that you see on the left. And then the gentleman who came in twice, actually, so once from a COVID pneumonia related admission, was discharged doing quite well and actually returned due to abdominal pain and was found to have a renal infarct of a remote transplanted kidney.
Okay. The other advantage of spending a lot of time on the COVID unit is that you get to see the late and the recurrent presentations to give you another idea of what the patterns are looking like. So this was a really interesting and puzzling case, I will say. So Mr. JC is a 72-year-old guy who has a history of hypertension and more importantly has a recent diagnosis of a lung cancer with 2 suspicious brain lesions that were thought to be synchronous brain mets. He had completed chemoradiation with carbotoxol at the beginning of the year, and he was planned for immunotherapy but hadn't started yet. He traveled to Florida and his wife started getting sick in Florida. Notice the pattern of the wife infecting the husband on a regular basis. But he started developing a fever and a dry cough. Tested positive for COVID on April 3rd, presented to emerge that same day. And his wife made him because he had persistent fevers and he's a cancer patient. So she said, you should probably get checked out. He was tachycardic and febrile when he came to hospital, but not hypoxic. His hemodynamics really stabilized after some fluid resuscitation. He was started on azithromycin for 5 days. His x-ray, I have a slide after this just to show you guys his x-rays, but he was never hypoxic and he was discharged home. He came back 4 days later with worsening dyspnea. This time he was treated with piptazo and azithromycin. The thought was that he may have a hospital-acquired pneumonia, although his x-ray wasn't really suggestive of that. Wasn't hypoxic at rest, but needed oxygen with exertion. So he was discharged home after a longer stay this time with PRN O2. Came back 6 days later with, again, worsening dyspnea, cough, recurring fevers, needed 5 liters of O2 per minute at rest. He had a pretty significant leukocytosis on presentation, got more piptazo, more azithromycin. The guy's like bathing in azithromycin by this time. Some cefuroxime eventually on step down. He had a CTPE, which was ultimately negative, and then he was again sent home with some oxygen at rest this time. And then within really less than 24 hours of discharge, he presented again to hospital with very acute dyspnea, a profound leukocytosis that was kind of spontaneous. He needed 8 liters per minute at rest. He again got some piptazo. And then his CT of the chest showed worsening consolidation and signs suspicious of organizing pneumonia. He was ultimately seen by respirology and started on steroids. So he started on prednisone 60 with a taper. And within 48 hours of starting the steroids, his fevers completely went away and he has not been back since. This is the series of his x-rays. So obviously there's an underlying lung malignancy here, but you can see that there was definitely a progression to denser consolidation, and these are slices from his CT scan at the time of the diagnosis of the organizing pneumonia, where you can really see that there's more kind of dense plate-like consolidation on the background of ground glass opacities. And when you look at that studies looking at the evolution of radiological findings in COVID-19, so those with kind of the earlier timeline for developing pneumonia, they usually have what we talked about initially, those bilateral diffuse ground glass opacities, which seem to decrease in favoring kind of mixed pattern with consolidation in that 2 to 3 week range. And that's what we've seen here anecdotally. We've had a few people now that have presented with organizing pneumonia, and they've all kind of been diagnosed within that 20-ish day range. And those people need steroids, and they do really well with steroids.
We've also had a series of patients that perhaps didn't quite present quite as typically as we would read or expect. Most of them, I will say, are probably more in the elderly population, and our patient age range was probably from 81 to 102, most of them from a retirement home. I used to call them my ladies of, I will blank the name of the retirement home, but they were all in one room, sharing a cohorted room. They mostly presented with either weakness, falls, overall lethargy, and some delirium or some GI symptoms, nausea more so than diarrhea initially. None ever really developed clear, overt radiographic changes or hypoxia. The most that any of them ever required was about 5 liters or 4 or 5 liters of oxygen, and that was one person who was previously on oxygen prior to coming into the hospital. Most of them were fairly asymptomatic from a respiratory point of view. So I guess this proves that not all COVID looks like the COVID you'd expect, and so you do have to keep a certain index of suspicion if people present with these non-specific symptoms, especially in the elderly, or if they certainly come from a potential outbreak facility. So we'll talk about some patterns we've seen over time. So just to point out, so we started off on the COVID ward sort of at the very onset, which was about 6 weeks ago now. We were on for a couple of weeks and then off for a bit and then back on. So we've actually seen a fairly different presentation over time.
Okay, so we found that women generally do better than men with this disease when the disease severity is such that people need admission to hospital. Again, just to illustrate, so Mr. and Mrs. G, both in their 80s. Mr. G had a few more medical comorbidities than his wife, but generally actually quite well, very active man, hiking in France around Christmas time. Both were remote ex-smokers, and both were quite independent at baseline. They spent 2 months in the south of France, and they returned early once the notice was issued that people should return home. They began to self-isolate immediately. They started to get fevers and chills around the same time. Interestingly, Mrs. G tested negative when she was first tested on March 30th, but he tested positive, although there's little doubt that they were both positive at that time. He presented to emerge a few days before she did, really again with syncope, GI symptoms and new dyspnea, and he was hypoxic on presentation, whereas she presented mostly because she was generally quite weak and wasn't very hypoxic when she first presented. These were their x-rays on presentation. You can see that his x-ray was certainly worse than hers. And their inflammatory markers. Unfortunately, we don't have Mrs. G's inflammatory markers on presentation. She was admitted to another service on presentation, and they hadn't kind of routinely started doing these markers. But he had evidence of end organ damage, and his inflammatory markers were pretty high. So he was admitted on our unit. We started hydroxychloroquine and Kaletra at that time. Within 5 hours of admission, again, he's another one who went on to have quote unquote 200% oxygen applied. He remained conversive and still very alert despite SATs in the 80s and kind of prolonged hypoxemia. But after discussion with him and concurrently with his family, the goal was made to focus on his comfort because we did not think that we would have a successful course. He spoke to me until his SATs were about in the 60s and then became drowsier, and he passed away within 48 hours of presentation. Kind of sadly, Mrs. G arrived to our ward 20 minutes after her husband died. So she was permitted to spend some time in the room. She initially transiently was more hypoxic, and palliative care was consulted for symptom management. There was also a lot of grieving going on, as you can expect. She developed some GI symptoms that were treated with Haldol, and gradually her symptoms improved, and she was actually weaned off oxygen and went home. The other thing that we found is that when things go downhill, they go downhill fairly quickly. So it's good to be on a ward where people are used to that and where you can react quickly. Another case, which just was last week, so a 90-year-old lady from a long-term care facility that was on outbreak, had some comorbidities that you would expect in a 90-year-old, but was generally cognitively quite with it and independent with her walker. She presented on May 4th with a fever, generalized weakness. She tested positive 48 hours later, presented to emerge 24 hours later with persistent fevers, but was not hypoxic, so sent back to her care facility, and then presented again on the 9th with persistent fevers, and at that time was delirious. Very febrile when we saw her, but on room air. Her inflammatory markers, again, you can see were elevated. Her CRP was in the hundreds. Ferritin, interestingly, was normal. Her initial chest x-ray was actually fairly unremarkable, but within 24 hours, she was on 6 liters. Within 48 hours, this was her x-ray, deteriorated very, very quickly. We did Doppler her legs. She had a chronic leg asymmetry, but we just want to be sure, and they were negative. Her LOC significantly worsened as she became more hypoxic, and then she was made comfortable and passed away very quickly. So things change very, very quickly in this disease.
One other thing that we've noted is sort of the importance of the 7 to 10 day mark after the onset of symptoms. This was also sort of published in the literature in a study out of Wuhan as well, but that people who really develop symptoms from a respiratory point of view, the dyspnea will range from 5 to 8 days, and then ARDS from 8 to 12, and the ICU admission range from 10 to 12 days. And in our experience for the 40 some odd patients we've had, on average, their initial sort of deterioration or needing admission was about 8.5 days from admission. Somehow it took longer for patients coming from long-term care, but for patients from the community, it was between that 7 to 10 day mark. We're going to talk about some people who I will refer to as the happy hypoxemics. So when you ask patients, are you sure you're not short of breath? So a brief case, so Mr. S is 66, he's had some comorbidities that were fairly well controlled, and he had a remote smoking history with a fairly independent baseline. I traveled to Lebanon and returned home on March 14th and started developing symptoms on March 29th. The classic COVID symptoms from a respiratory point of view, tested positive on April 7th and presented to the emerge on April 8th with worsening cough, shortness of breath, and fever. Was about 86% on room air when he was first admitted to us. Again, sort of inflammatory markers were high, this was his initial chest x-ray on presentation. So on the day of admission, he really required 3 liters, was started on hydroxychloroquine and ribavirin and some antibiotics. Within 24 hours was up to 60% FiO2. And then on about 5 days after his admission, they were just moving him to a chair, and he desatted and needed 100% FiO2 at that time. So our RACE team, so our ICU team was called, and while they're assessing him, his SATs are in the mid 80s, and he is telling them an entire conversation. I can can see the hands moving, he's just chatting, and he's completely oblivious to the fact that he is sitting in the low 80s. He was transferred to the ICU, was never intubated, and was maintained initially on 85% of FiO2. Was started transiently on full dose IV heparin, even though he had no evidence of clot, and then was transferred back to our ward subsequently thereafter, and was never intubated, and eventually went on to rehab. But all this to show, and there's tons of things published either in real medical literature or on Twitter of these happy hypoxemics, of people who had SATs that you would almost think would not be compatible with life. Yeah, let me just. Sorry, I guess you're seeing this. There you go. You see at the bottom, there's a picture of a patient who's scrolling on her phone with SATs in the 50s. And we have seen this of people with not so great SATs who are completely oblivious. And if you ask them, are you short of breath? They will say, not really. The thought behind that was that either there's a component of intrapulmonary shunting due to atelectasis, that these people have a fairly preserved lung compliance and that is not the issue, or that there's a lack of excessive dead space, which actually allows for the appropriate clearance of CO2 so you don't accumulate, which therefore doesn't drive your respiratory rate, or that there is really a dysfunctional hypoxemic vasoconstriction. So normally you would vasoconstrict to the areas of your lungs that were dysfunctional or damaged, and that this doesn't happen in this disease, and therefore your SATs are lower, but your oxygenation is therefore lower, but that your ventilation is sort of maintained. So these were sort of the two types of sort of the classic ARDS presenting symptoms and the non-ARDS type. And so for the non-ARDS, they were really trying to really minimize the intubation. And so we just kept them on high flow oxygen and tried to limit their PEEP. Whereas the true sort of COVID type H with decreased lung compliance, we would treat as regular ARDS. Pearls in terms of treatment. So as you can see from the cases we talked about, so the initial cases we actually did treat more frequently with hydroxychloroquine in hospital, based on some of the evidence that was showed earlier in the management of COVID. Though there have been more and more studies that have showed that there really is no real association or improvement in either intubation or death or length of stay in hospital. So we have essentially at this hospital stopped using hydroxychloroquine for the management of COVID-19 patients. And this was another study that looked at both hydroxychloroquine and azithromycin, either alone or in combination. And again, there was no difference in mortality between the two groups either. Ribavirin we were initially using as well, and it had been shown in terms of MERS perhaps to have a better role for that. So the initial thought was that perhaps it could be used for COVID-19 as well. And it doesn't come without a series of side effects, and was also probably better use with Kaletra in combination. And so when we started our Kaletra study, and we were using only Kaletra as for people who were part of that study, we stopped using ribavirin alone because it probably wasn't shown to do much. And I will say that it was fairly poorly tolerated from our patients. And so often we ended up stopping mostly due to GI intolerance.
In terms of the things that we're still kind of semi-actively using, so lopinavir, ritonavir, Kaletra, the rationale to use it in COVID is really that there was some evidence in other coronavirus infections. So in SARS and in MERS, although in MERS it was mostly in vitro studies. The study that most people quote is this New England Journal of Medicine study, which was a very small cohort, 100 randomized to treatment, and there was really no clear benefit. But kind of the secondary post-hoc analysis, which is probably the theme of the recent literature that's published on COVID, is that we're creative with analyses. They showed that there may have been a benefit when it was initiated within less than 12 days of onset. So at the Ottawa Hospital, we do have a trial called the CATCO trial, which is randomizing people to receive Kaletra or not on presentation. In terms of Anticoagulation, so we spoke about the fact that there is definitely a high VTE risk. Just to remember, though, that this is not unique to COVID necessarily. We know that critical illness itself is associated with a higher thrombotic risk than normal state. Some of the studies that show really high thrombotic rates coming from China may have been skewed by the fact that they do not routinely use VTE prophylaxis there. However, the studies from France and from the Netherlands, where VTE prophylaxis is the standard of care, they do show that there's a higher risk of thrombosis in those critically ill patients. There are a number of trials that are going on right now to determine what the right dose of DVT prophylaxis is, and currently at the Ottawa Hospital we are using a intermediate dose of 0.5 milligrams per kilograms BID. And there's even some consideration about potentially trialing therapeutic anticoagulation. The recommendations from the big societies like the American Cardiology and Hematology Societies is that, this should really be only done in the context of a trial because we don't know what the right evidence for this is. The other thing that I think is probably the most interesting study that we have going on is convalescent plasma. So again, plasma from individuals who have developed neutralizing antibodies given to patients either with infection or prophylaxis. We're really doing only the treatment here. And the thought is that you would have a cellular toxicity and phagocytosis mediated cure. There are some prior studies that have shown that convalescent plasma can be used, again, in influenza, SARS, and MERS, but small studies, there was an improvement in the odds of mortality. And it's good to know that there are some small studies that have some encouraging preliminary results in COVID-19 in terms of improving hypoxia and changing viral load. So in terms of the bottom line for treatment, hydroxychloroquine really is not supported by evidence, so we're not using it. Antivirals, they may potentially be helpful, but we're really leaving that to trials at this point. We feel here that it's reasonable to use a higher dose of DVT prophylaxis unless there's a contraindication to doing so, but there are trials looking at that as well. Convalescent plasma is very promising, but we're quite limited by the available supply at this time. We just like to remind people there's really little harm to treat for bacterial superinfection, especially in those who have kind of a dense consolidation picture on X-ray. You may not need to give 2,000 days of azithromycin, but it's worth considering. Also, just important to point out that not to forget about co-infections. We've actually had 4 patients that have a co-infection with influenza B. That was earlier in April, so now we're kind of tapering out of the influenza season, but just something to keep in mind. And then there was some concerns initially about avoiding steroids and NSAIDs, but just that if somebody presents with organizing pneumonia or has an underindication for steroids, it would still be worth considering because people do get better from that point of view. We've added a few resources here in terms of looking at some of the literature. This website is actually really good for summarizing some of the ID papers that are in press. And the CDC website actually has some pretty good information as well. And then just very, very briefly, we were asked to talk about how you manage life on the COVID service. So, I think that working in pairs or in teams where possible is really important. It's important for support, bouncing ideas off of each other, and really being mindful of the PPE. Having somebody watch you don and doff PPE is really important. You should not be in a situation where you have to accept subpar PPE. The COVID ward here, we have really been very strict about what we will wear and what we will not wear. There were some questionable plastic gowns that we have not worn, and so we've been supplied very appropriate PPE. Travel light, meaning that, you don't need your own stethoscope. There should be a stethoscope dedicated in every room for the patient so that you're not carrying those things back and forth. We weren't wearing, lab coats and things like that. We were really bringing minimal things on the ward. the Ottawa Hospital has really leveraged technology to our advantage, and there are some fancy things that we're doing in terms of cameras in rooms and things like that so that we can see patients, but also fairly low-tech things like baby monitors so that you can talk across a closed door to each other when someone's not doing well, so that you're not opening the doors back and forth. We've used iPads to communicate with families, which patients have really appreciated. One thing is that you have to accept that a very large part of your job will not necessarily be medical, but more communication driven. And that includes communication with your team and your colleagues and the people who work around you, but also communication with families. I would say that half our day was spent making phone calls most of the time just to update families, because people are really, really worried about this, and not being able to come into hospital to see your loved one is very challenging. So keeping families in the room and in the loop, and then relaying that back to patients has actually had a huge therapeutic effect, I think has been really important. I would say on kind of a lighter note celebrate the victories. There are some victories. We have discharged people home. We have discharged people to rehab. The rehab center here has a dedicated COVID ward, and people do get better from this. Not everybody has a bad outcome, and I think that you really have to hang on to some of those things. We've also said, it's important to kind of accept and give praise to people. Recognition is really important for morale, and that comes from the way that you talk to your team and making sure that everybody knows that they're a very important part of it, from the person who cleans the rooms to the nurses, the people who delivers the PPE, to the people who deliver food and things like that. It's really important. And then something that we have both found is that when you've done COVID all day, every day, you go home, like, you don't want to be doing COVID. So just turn off the social media and the news, and just do something different in terms of keeping your sanity up. So the pictures there, so that there's Isabel and I and our amazing team on the COVID unit here at the General. And we're happy to take any questions.
That's great, guys. That's a great overview. There are a few questions. I'm getting a little bit of feedback. I'm not sure why, but that's okay. There are a few questions that have come up on the chat. If there are more, please type them in. The first one is more of an epidemiology type question. So Dr. Sharma had to leave. And the question is, how big is the second wave going to be, and when is it going to hit? So some of you may have seen, there's some media reports out there that in the late summer, early fall, people are expecting what's termed the second wave. We don't know how big it's going to be, but there are two factors that are going to impact it. One, of course, is social distancing. So there is a website, it's 613ottawa.ca, which is an academic website run out of the TOH, which provides epidemiological models on how big waves are going to be, depending on various factors. And the biggest one is our ability to socially distance. If we can maintain social distance, then the wave will not be that big. If we cannot maintain social distance, then the wave will be big. And how big will depend on the degree of social distance that we can maintain. The other factor is one that we haven't really addressed in society yet, is the testing and containment. So we don't have widespread testing yet. When it is available to us, it'll be much easier for public health to identify cases, to slowly quarantine them, and to break the chains of transmission that will occur. And that, when it is available, will have a huge impact on any potential waves that will develop. The third, of course, is when that wave will, and so I guess the third is the relation of that question to what is the impact on our healthcare system, our individual hospitals. And that will somewhat depend on the size of the wave and what season we're in. The difference in late summer will be, the difference between late summer and early winter, of course, will be flu season and the concomitant illness there. So there is still a lot of unknowns out there. We need to be prepared. We need to be ready for this because it will come. The extent of it we don't know, but it will still be there. The second questions were really actually related to clinical. One of them was answered in the presentation regarding the risk of VTE. Another one is, do we do CT chest on anyone who has an elevated D-dimer to rule out PE in the context of COVID? Sam, Isabel, do you want to address that?
Sure. So we haven't been doing routine CT scans on those on everyone on presentation. The index of suspicion is obviously higher in those patients who have very high D-dimers, so usually those that are in the over 24,000 range. So our strategy has been that we are doing CT scans in patients who have kind of a sudden deterioration in respiratory status or new hypoxia and were otherwise well, or whether or not their hypoxia doesn't correlate to their chest x-ray findings. And then we've been doing CT scans, but we are not doing them routinely on everyone. And the big reason for that has just been exposure. We are trying to minimize exposure and transferring the patients to diagnostic imaging if we do not have to. We do have a dedicated ultrasound tech who is coming up to the ward to do leg Dopplers. And so if patients are stable enough, that's usually the route that we will take first. And if the Dopplers are positive, then, you know, we don't necessarily need to bring them down in the elevator and across to diagnostic imaging. So that is the approach that we have been using.
Okay, great. There's a few other questions. So what percentage of people would be called asymptomatic carriers? We don't truly know that answer, but there have been some point prevalence studies that were done in the United States, which demonstrated anywhere between 30 to 50 times the number of people who are actually found to be COVID positive are truly COVID positive, meaning that if there is 100 people who are identified as COVID positive, the real numbers in society are 3,000. And I think for those of you who were paying attention to the news a couple of weeks ago, when we started first doing our lockdowns here in the Ottawa region, that our Chief Medical Officer of Health was giving us some wide variables, and it was based on the fact that we're not capturing a lot of people and the real rates are much greater than what we're really seeing, which leads to the initial point of when we do some broad-based testing, we'll be able to find these people, isolate them, and break the chains of transmission. One other question that's related to is some of the lab work and predictors of who is going to get sick. So this relates, there's two questions related to this. The first is that someone wrote saying that they'd seen someone recently who had symptoms of COVID, but were who they thought had COVID, but were relatively asymptomatic. And so they sent home with advice to return to emergency if they turn worse. That's not an uncommon thing, and that's been done quite a lot in a number of the institutions that I'm aware of. So the real question there is, how do we know who's going to get sick? Is there anything that can predict who is going to become ill? Sam, Aaron, do you want to first pass at that before I talk? Sam, I mean?
I think I don't know that we can necessarily predict very well those who will get sick and those who won't. There are some predictors in terms of comorbidities and things like that. So we've seen that in terms of hypertension, diabetes, those types of things, and those who are older as opposed to those who are younger. But beyond that, I think our experience has also been skewed in that we've only seen people who have been in hospital. So I'm not sure that we have a good eye for that.
There are some studies that are coming out now. You know, we have about 4 to 5 months of experience with COVID internationally, and there are some studies that are coming out that are looking at prediction tools, scoring tools. As one of the ones that seems to have some credence is a neutrophil to lymphopenia ratio, or neutrophil to lymphocyte ratio. The role of AST is being looked at, and you might have noticed with a lot of their presentation, they were looking at the inflammatory markers, and there's some evidence to suggest trending the inflammatory markers to see if people are going in a direction that's taking them more ill. But as they mentioned, there's nothing concrete, and these are all still in nascent levels of description. Nope. What is the current prevalence of COVID-19? Some antibody testing suggests 10%. I don't know. I guess there's antibody testing that's being done internationally. There's none that's licensed in Canada that I'm aware of, and there's no serological testing that's being done at present, perhaps outside of any research context. Like I said, sorry, I'm on call too. Like I said, we can estimate the numbers to be anywhere between 30 to 50 of what is actually been captured through testing now. Let's see, is there any other questions? Sam, any advice on people, or Isabel, any advice on people who, you know, they see them in the emerge and they're looking well, when to come back or whether they should be admitted? I guess that's a big question, is should we just admit everyone we are suspicious of COVID?
I don't think everyone needs to be admitted. I think once you've seen a few sick COVID patients, you start to know what they look like. And so I think if they look well, if they are a reliable person who will know when to come back if their symptoms get worse. Public health also, once they've been identified as positive, will also follow up with them with phone calls. And so they have someone that's kind of checking in on them as well. I will say we talked about it this week, and I'm sort of referring to the happy hypoxemics to say, if you wait for the moment where they're actually short of breath, you may wait for a long time, or they may be more hypoxic when they present because they are not always aware of their hypoxia. But I think if someone looks well, is hemodynamically stable, is not hypoxic when you see them, and are reliable, I think they are safe to be discharged home. And I think if they are followed by public health and if things change, then they probably would present back again. I think if you have people who are not reliable, or just something tells you that there's just, they're not typically necessarily very tachycardic, they're not usually hypotensive. And so if you have any of those other findings, then that may be an indication that they would do poorly. I think in some ways too, if they present later, so if they were diagnosed 10 days ago and they come because, I think that may be very different than if they were just diagnosed 3 days ago and they're very symptomatic at that time. That may indicate that 7 to 10 day mark, they might do worse from that point at that point in time. And so one of the patients that Sam referred to from the long-term care facility, who had 2 emerge visits before she came back from her 3rd one, just at that time frame, she had the potential of getting worse before she got better. And so that's part of the reason we actually admitted her, even though she really wasn't hypoxic when she first presented to the hospital. So it becomes a bit of a clinical intuition, but also I think if you're reliable quite well, you could probably go home.
Great, thanks. There's one question. So next week, we're going to talk about the infectious disease specifics of it and some PPE. Related to that will be lab testing, but there is one question here that I think is quite pertinent, is when would you consider a test is false negative? And what would you do about it, particularly in an asymptomatic or in atypical symptoms in an elderly patient? Do you guys want to take a first pass at that one as well? In a negative test in someone that you suspect has COVID?
So those are always tricky, especially in the symptomatic patients who present with hypoxia and fevers and who they have a contact, they're from a care facility, and they test negative. We just treat them as if they have COVID. We do the same precautions and things like that, and we'll repeat the testing. The tricky part is the atypical presentation patients. So the patient who's from a long-term care facility who fell and has a bit of diarrhea, like what do you do with that patient? So I would say the safest thing is if you're not admitting the patient, you're sending them home, you may have to make sure that they are able to self-isolate. And we recommend that they do that for 14 days. And if you are admitting them to hospital, if your index of suspicion is high enough that it's lingering in your brain, they should remain on contact droplet precautions. And either you retest them or you keep them on that precaution for the duration of their hospitalization. That comes at a PPE cost, but an outbreak is much more costly than that.
Great. Okay, I don't see any other new questions right now. Unless there's any questions that pop up in the next 30 seconds or so, I'd like to thank our presenters, Dr. Sharma, who had to leave, and of course, Dr. Halman and Dr. Desjardins for excellent presentations. I hope everybody out there found that they were useful. As mentioned, this is the first in a series of presentations that we'd like to present to the Eastern Ontario region regarding COVID. And the next one will be about infectious disease specifics, PPE, and lab testing in general.
So, Sunil, there's 2 more questions.
Oh,
that just
sorry,
popped
did
up
I
there,
just miss?
so.
Okay, my apologies. Oh, okay. any insight to impact of COVID in the pediatric population? Oh, and then there's a question about the impact of COVID on if there's an impact on COVID in marrow suppression. I have to say I don't have an answer regarding the pediatric population, aside from what's been anecdotally reported in the news. Sam, Isabel, I don't know if you have any further details about that.
Pediatrics is outside of our area of expertise. We don't see kids.
Sure, fair enough. So I'm sorry, yeah, unfortunately we don't have any details about that, but we could perhaps find some information presented next week, just a small snippet. And then regarding the last thing about, I've noticed that most of the patients you presented are anemic based on initial labs. Is there any indication that SARS-CoV-2 causes bone marrow suppression, bleeding, DIC, or hemolytic anemia?
So none of the patients have been in DIC and none have been hemolyzing. So like any infection, I think that there could be an element of infection-related marrow suppression. But all of the patients who were initially anemic did recover. Actually, the patients who eventually were discharged home, their anemia recovered. So I think it's a transient effect of the infection itself, more so than a more ominous thing like hemolysis or DIC.
Great. Perfect, thanks. Okay, everybody. Again, I want to thank everybody. I want to thank our presenters, and I want to thank. Sorry, I'm just getting a notice that there's more questions, but I'm happy to stay and do the more questions. They just don't show up easily on my screen here. Oh, okay. I happen to see this one advertised on Facebook. How do I connect to future virtual sessions if I miss it on Facebook?
We're writing the response to that, so we should be good.
Oh, okay. And
the 14-day isolation suggested
yes.
10-day was the last one.
Yes, I'm sorry. So regarding asymptomatic COVID positive patients and the duration of isolation, most evidence suggests 14 days. However, some have suggested 10 days. What's the evidence for shorter isolation, and are there any instances where it could be applied? So the actual public health guidelines will say that for COVID positive patients who have symptoms that are now resolved, so i.e. you came in with a cough and shortness of breath, and those have resolved, you can retest to confirm that their COVID status has changed to negative. And retesting means 2 tests done 24 hours apart, which are both negative. The official guidelines don't say 14 days, but we have pushed them out, generically speaking, amongst the region to 14 days because the PCR test is quite sensitive in picking up small snippets of DNA, and it's quite often that the test will be positive within the 14-day period. I'm sure Sam and Isabel have noticed this at the Ottawa Hospital, and we've noticed it much at the Queensway, that even after 14 to 21 days of an asymptomatic patient sitting on the wards, we test, and they're still showing up positive for the COVID. What that means from a clinical perspective is probably nothing, but from an epidemiological and an IPAC perspective is pretty significant. So we are not testing anybody less than 14 days here, simply because the chance of actually being negative is quite low. I don't know, Isabel, Sam, if you concur with that.
Yeah, it's been the same. We've had people that have actually tested positive now for 5 weeks in, the reason that we're testing them is really to try to get them off the COVID ward. In some cases, some of their facilities are not on outbreak, and then they need 2 negative swabs to go back to their facility. So that's the reason we've been testing them. But patients have been asymptomatic for days and days and days and still test positive. And
we'll get a negative swab, and then we'll get a negative swab one day and a positive swab the next, and we're not really sure what that means. And obviously there's some sampling error. You have to be able to do a true nasopharyngeal swab and not just catch perhaps the tip of the nose when you do it. And so that might account for some of those negative tests and then subsequently come back positive the following day. So it's been a bit challenging to get 2 negative swabs for people in hospital. I don't think I know anybody with 2 swabs at the 2 negative swab at the 14-day mark.
Yeah.
Yeah, I think I can think of just 1 or 2 patients at all. Okay. All right, so I hope that answers all the questions. Yeah, okay. I hope that answers all the questions. Have a very good night. And again, thank you for participating today.